Chapter 21 is about impulse control disorders. Many of these may have history of parents who may have been abusive, maybe rejected them, maybe overly controlling, or maybe the parent had substance abuse. A lot of disruptions in the family, maybe spousal abuse, a lot of marital fights between the parents, separation of the parents, or even going into foster care. With oppositional defiant disorder, also known as ODD, these individuals are very negativistic. They are disobedient. They are very defiant towards authority figures without seriously violating the basic rights of others. Whereas persons who will see with conduct disorder frequently behave in ways that do not violate the rights of others and have age-appropriate societal norms. With oppositional defiant disorders, as you see here, they're angry, very irritable, very vindictive, defiant, kind of like sometimes typical teenagers are, but these go on and above the call of duty, so to speak. They are in an angry mood. They can lose their temper, become easily annoyed by others, telling people, get away from me, she's bothering me. And it can also be seen as a defiant disorder, arguing with the parents, refusing to reply to any rules or requests that they may make on them. So again, they usually show patterns of deliberately annoying people, blaming others for his or her mistakes or behaviors. Maybe saying, it's not my fault, they made me do it, kind of situations that we'll see. They're not, a child with oppositional defiant disorder is not just a child who is difficult or defiant, but it actually starts to impair their entire life. And so it's hard for them to attend school, have friends, and just function as a member of their own family. If they're left untreated, some may outgrow this disorder. However, most of people do not, and they continue to experience a lot of difficulties in society and conflicts with authoritative figures, and start to have school issues that start to impact their entire lives. So ODD is usually a repeated and persistent pattern of having an angry and irritable mood in conjunction with demonstrating defiant and vindictive behaviors. Your intermittent explosive disorder, these patients have repeated and persistent patterns of having an angry and irritable mood in conjunction with being very aggressive, and so they can't control this aggression that they have, these impulses. Usually it's adults 18 years or older, and it can lead to problems with interpersonal relationships, occupational difficulties, and actually ends up committing crimes that we may see. Their aggression can be verbal or physical, and it's usually targeted towards other persons, maybe animals, property, or even themselves. Anything can trigger this reaction, just a simple little thing, and so they may punch their fist through a wall because they can't find something that they're looking for. They may destroy their room, break furniture, and so the rage continues, and they may, until someone intervenes or they cause injury to themselves or someone else. The behavior, they'll show repeated patterns and interference with normal functioning of everyday life. They scream and curse, at individuals they work with, and so they're just absolutely out of control. They go from being upset to being very remorseful. And so they'll have this tension, it'll build up, they'll explode, they're remorseful, and it starts all over again. And again, it can affect their personal functioning, everyday life, not being able to control this. Conduct disorder, the behavior is usually abnormally aggressive, and they start to have conduct issues. With conduct disorder, we're going to see some problems, and we're also going to see the onset of the disorder in two different sections. So we're going to look at that on your next slide. Childhood onset conduct disorder is prior to 10 years of age. Adolescent onset disorder is not before age 10, and it usually occurs, we start seeing it occurring with their peers. There's two problems that you'll usually see with the adolescent, and that's going to be pyromania and kleptomania. On page 403, they actually look at some comparisons of the different disorders, your oppositional, your intermittent explosive, and your conduct disorder. Your conduct disorder, they actually get into criminal activities, and actually can lead up to what we call antisocial personality disorders as well. Their violations of others and their aggression to others and people and animals, and their destruction of property, being deceitful, violating rules, is all unimpulsive, whereas intermittent explosive is impulsive, and your conduct disorder, it's not. They are not impulsive at all. They actually plan this. They actually are really don't care if they violate the rights of others and they hurt others. They want to see what happens. They're that mean kid who will pour salt all over a slug just to see it wither up. I mean, that's the type of kids that these are. I have a YouTube link for you to look at on conduct disorder. Some of the biological factors is that we do see less gray matter when they've done scans on these individuals. And psychological factors, they have immature coping and problem-solving skills, and it is, they say, id-based. When you think about Freud, the id, the ego, and the superego, it's all about themselves. Environmental factors, it can be a learned behavior or modeling. Maybe a parent or an older sibling acted this way. They saw the attention. They thought, this is how you act. This is how you treat others. And so it may be learned or modeled. Or they have a very disrupted family environment. And sometimes this is anger that they're trying to let out in a form of release, I guess you could say. Again, there are some comorbidities that go along with this, such as ADD, ADHD, anxiety, depression, suicide, bipolar, and substance abuse that we will see that go along with this disorder. On our assessment, one of the things we have to look at, of course, is safety, and we always mention that with every chapter, is looking at safety issues, and are they at risk for hurting themselves or others. So we want to determine the cause of their stress and the risk of their violent acts. But the nurse must also listen, to any person expressing any wish to hurt themselves or others. So we're going to do a suicide risk and ask several questions to assess whether they are at risk. And so on page 404, they have some bullets under suicide risk. I'll let you read those. I'm not going to read those out to you. They also have some assessment tools. So if you want to look over at the tools on page 405 and look at some of the how they define either oppositional defiant disorder or conduct disorder, you might be curious. You might even want to do the test on yourself just to see where you are in there. So we do have those tools. Self-assessment, we have to look at ourselves and, take care of ourselves and realize, it's them, it's not us, and sometimes it can be very difficult working with these individuals. another thing that you want to look at, I love the assessment guidelines that they have on page 406 when they talk about the different disorders and what you would want to assess for. So these are very, very helpful. So please make sure you look through those. As far as your diagnosis, some patients will have failures to follow age-appropriate social norms and an inability to problem solve by using adaptive behaviors in order to meet life's demands and roles. Conduct disorder, the aggression is against people and animals, the destruction of property, being deceitful, rule violations, and they have an impairment in social, academic, and occupational surroundings. So some of your diagnoses are going to focus on whatever may be happening or protection towards others or themselves from impulsive acts or either planned acts of harming themselves. We want to look at improving their coping skills and addressing the family. Depression is also associated with your impulse control disorder. In teens, we will see self-imposed isolation, especially after they have that outburst. Remember I was telling you how they have that cycle where they build up the tension and they finally have the outburst, and then they feel bad about it, and they'll calm down and be remorseful, but then they turn around and go at it again, unfortunately. They have some outcomes on page 406 in the purple box alongside the diagnoses. And again, we want them to express themselves and verbalize things and not be acting out physically. So again, learning how to control and identify those behaviors and what triggers those, what can be effective and ineffective coping skills, talking through something or punching through a glass pane. Again, we also want the family and caregivers to participate in their programs and in their treatment and help them to learn appropriate parenting skills. And with some of these children, you can't just do normal parenting. I mean, sometimes it's tough love. Medications are not generally indicated for your oppositional defiant disorder. Comorbid conditions that increase these any kind of defiant symptoms, such as ADHD meds, may be prescribed. One of the things that we have to make sure that we do is set limits. Use clear, sharp statements about prohibited behaviors, and use guidance for performing a behavior that you want or is expected. When you think about the health teaching and implementation, again, you want to promote safety for the patient and others. You also want to establish a good rapport with the patient, set limits and expectations. Make sure you provide structure, rules, and boundaries. Provide activities and opportunities for them to achieve their goals, and that gives them that sense of purpose that they are reaching something. And you also want to consistently follow through with consequences if they break a rule. No passes as far as that goes. On page 408, 21.1, they have a lot of techniques for managing disruptive behaviors. So look at that box. That's really interesting. Some of the, like I said, pharmacological interventions that we may use, especially with comorbidities, can be your antipsychotics and Haldol and Chlorzel. Again, we want to work with the caregiver, the parents, and the child when we're doing health teaching and health promotion. And again, that's on page 408, which can be very helpful. Looking at some of the therapies listed here, the PCIT, which is your parent-child interaction therapy, this is where the therapist sits behind a one-way mirror and coaches the parents through like an earplug audio device while they are interacting with their child. And this therapist can actually suggest strategies that reinforce positive behavior in an adolescent. The goal is to improve parenting strategies and reducing problematic behavior. So it has them going through these situations and helping the parent become more I get comfortable and used to using these strategies, and instead of getting home and and for lack of a better word, freaking out when their child freaks out. And so this is going to help them and promote them to have a better understanding about the type of therapy and how they should be relating to and communicating with this child. I have one more YouTube video for you to watch here. And then the other is, you really want to think about, again, teamwork and safety, seclusion, restraint. I'm going to go ahead and add in communication, and then go back and evaluate. Seclusion and restraints may be necessary, but only as a last resort, especially with working with those who have impulse control disorders. Time out and quiet areas may be helpful, just reducing the stimuli and what's going on and being in a different environment. So that can help. Sometimes, even though the restraint may be necessary, sometimes it can even make them worse, and it becomes even a bigger ordeal than it really should have been. So that should be used always as a last resort.